So, Exemplar 29B for the remainder of this module 29 is personality disorders, starting on page 2003, 2003. So, personality disorders are a pervasive pattern of behaviors, personal perceptions, inner experience that are significantly incongruent with cultural expectations, typical onset during adolescence into early adulthood. There's 10 personality disorders, but characteristic patterns of thinking, feeling, and behaviors that make an individual unique is your personality. Traits are hundreds of elements that make us unique, and the disorder results in repeated conflicts and impairs the individual's ability to function in society. Oh, I think I just did. Well, so when I moved, I redid the slides over to split them, and I guess I did this slide twice. Confused myself. Okay, so symptoms. Interpersonal difficulties. This is general in all personality disorders. So interpersonal difficulties identify problems, weak sense of self, lack of intimate relationship, clumsy social skills, manipulation, narcissism, and impulsiveness in general in all of them. Pathophysiology, 3 common behaviors of all personality disorders: manage stress by trying to change the environment, not themselves. It's everyone else's fault, not mine. They fail to assume responsibility, show lack of understanding of how their behaviors affect others. Egocenotic, behave according to their beliefs, desires, and values that concur only with their disorder. See themselves as their own behavior as normal, see problems as arising from external to them, it's not their fault, and often believe they are being victimized. This is on page 2004. Etiology. Many beliefs, they think it's a combination of everything. There's high link to genetics. Neurobiology, that genetics impact, that genetics, in addition to developmental things, increase the chance of a personality disorder. Traumatic history, early life stressors that aggravate things, or they maintained or they recur. Absence, abuse, or neglect can be part of post-traumatic stress disorder resulting from that. Interpersonal factors, the parent-child interaction, especially parental separation, parent being incarcerated, continued changing of caregivers or care institutions, so in and out of foster care, abuse and poverty. Sociocultural, they don't really know because there's different parts of society and different countries, so they're not sure where that factors impact it, but they believe it does. Risk factors are genetics, family life, child abuse, and being diagnosed with another mental health disorder. Most individuals' personality disorders don't come to the attention of a mental health professional because they don't see themselves as abnormal. Usually they end up in the legal system or some other problem, and that's where they get evaluated and actually diagnosed. So, in talking about personality disorders, the 10 they have grouped into 3 clusters. Cluster A is odd or eccentric behaviors such as being solitary, social anxiety, underachievement, hypersensitive, idiosyncratic fantasies. Cluster B, dramatic, erratic, chronically unstable behaviors in early adulthood, lack of any impulse control. Cluster C, avoiding, dependent, obsessive, compulsive, increasingly shy, and avoid social interactions. Antisocial personality disorder on page 2006. Oh, I should say here, there's table 29.4 on page 2007 is extremely helpful understanding these, and also going back, let's see, page 19, yes, 1983. Personality disorders are listed in the bottom of that chart. It gives you some generalized things and treatment overall for them. And I think there's another section. Oh, sample psychosocial assessment in 29.3 takes this whole concept of self, personal identity, personal history, communication skills, behavior, role performance, body image, self-esteem, on things you're looking for to assess those. Look over your culture and personality disorders on page 1987 also. Okay, so back to antisocial personality disorder. Propensity to manipulate or violate rights of others. It's antisocial. Risk factors: having a caregiver with antisocial or alcoholism, being a victim of child abuse, 4 times more common in men than women, commonly seen in prison. That's where because the antisocial is how they end up where they end up, unfortunately. Dishonest, irresponsible risk takers, criminal behavior, cannot form intimate relationships. They're aggressive despite lack of long-term planning, exhibits confidence in future success. They're unrealistic, easily agitated, and hostile. Antisocial personality characteristics: egocentric, lack of empathy, inability to form and maintain intimate relationships, antagonism, and disinhibition. Often include deceptive or coercive behaviors. Antagonism and disinhibition do not hold back. Clinical therapies: group therapy, anger management. Anger management's a biggie. Psychodynamic therapy, some pharmacological therapy. See on the chart that's on page 2011, pharmacological antidepressants, mood stabilizers, anti-anxiety, antipsychotics. Avoidant personality disorder: extreme discomfort, socially hypersensitive, easily internalizes everything. Poor social skills, extremely sensitive to criticism, profound distrust in other people's interests or relationship building. Management with them is social skills training, cognitive behavior therapy, group therapy, antidepressants, and anti-anxiety meds. Borderline personality disorder: impulsive, unstable emotions, depression, self-harm, often not common non-suicidal self-injury, NSSI, like cutting. Identity disturbances, transient paranoia, frantic attempts to prevent real or perceived abandonment, difficulty managing anger. Box 22. Let me see. Excuse me. Box 29.2. See if there's more there. Intense fear of abandonment is a biggie. And page 2011. Unstable relationships due to intense mistrust of others. So, see here, next page, borderline personality, clinical therapies, pharmacological, if you can get them on something, because they tend to not believe anything's wrong, but if you can, antidepressants, anti-anxiety, antipsychotics, and mood stabilizers. Behavioral dialectical behavior therapy, individual sessions to teach new skills, making patient responsible for changing these unhealthy patterns instead of blaming everything outside of them. Cognitive behavior, schema focused therapy. If you remember schema, hopefully from your developmental psych and from PEDS, schema has to do with your Piaget. I couldn't remember which theorist, it was Piaget. Group therapy and steps therapy, systems training for emotional predictability and problem solving. So for borderline personality, this dialectic behavior, schema focused, and steps group therapy. Steps is 21-hour sessions led by a social worker. Just look at page 20, 2006. Self-harm is common. Splitting, the inclination to perceive people or situations as one or extreme or the other, all good or all bad. This feature contributes to their frequent extreme shifts in mood. Identity disturbance, frantic attempts to prevent abandonment, real or perceived. It's very, very difficult. 75% are diagnosed in women. 20% of psychiatric inpatients have borderline personality. Risk factors, child abuse, abandonment. Strong genetic link, 5 times more likely if a first-degree relative had the disorder. Okay, keep moving. Defiant personality disorder is on the bottom of page 2008. Also in your chart on 2007. And there's some way back. Let me see. In your exemplar. I think. Anyway, I don't know. I can't find it right now. No. Okay. So, pervasive need to be cared for, impaired self-confidence, dependent personality, difficulty with decision-making, separation anxiety, tend to seek out dominant partners, can be predisposed due to chronic physical illness, diagnosed more frequently in women than men, may experience mild impairment in occupational social relationships because they cannot be independent. Let's see, I think there was something else. Let me see. No, that's it. On that one, histrionic personality disorder, page 2009, focus on self interferes with establishing and maintaining relationships. They demonstrate highly sexualized behavior. They like to act out with suicidal behaviors. Motivation is rooted in search for excitement and activity, difficulty establishing interpersonal relationships. This histrionic, they're flamboyant, they're very dramatic, they're highly sexualized. They do not do well with any kind of group therapy. If you look on, where is it? Personality disorders, clinical therapies, page 2011. Histrionic, psychotherapy may be effective. Group therapy is not recommended because of attention-seeking behaviors. Narcissistic personality disorder, page 2009, grandiosity, inability to empathize, attention-seeking, may have co-occurring substance abuse, eating disorders, depression, dysthymia, social withdrawal, extreme reliance on others' perception or inflated sense of self. Even though they act and think they can do no wrong, they also need that feedback constantly. Approval seeking, and extremely low or high personal standards. They can push themselves a lot, or they can be in the gutter. It's 50 to 75% are men. Difficulty developing meaningful relationships. Cognitive behavior therapy and family focused therapy are the treatments. They may be on antidepressants and anti-anxiety meds. I had it on pause, I guess. Did I cover this obsessive compulsive? In case I didn't, it's not the same thing as obsessive compulsive disorder, because the person with OCD knows that that is not normal, but this person sees their behavior as normal because it's a personality disorder. Men twice as likely as women treat with SSRIs, your citalopram, escitalopram, fluoxetine, paroxetine, and sertraline. Those are your SSRIs in cognitive behavior therapy. I'm sorry if I repeated that. Paranoid personality disorder. On page 2010, let's see, they have inability to trust others. They're paranoid. Paranoid personality. Actions of others assumed to be malevolent, rigid, inflexible worldview, hypervigilant, pathologic jealousy can damage relationships, tend to be prejudicial, judgmental, reject logic or proof that contradicts their beliefs, certain that other actions are prompted by hidden motives can lead to patients' self-isolation, family context, conflicts, occupational impairment. There's evidence of increased prevalence if a first-degree relative has schizophrenia or other psychotic disorder. Treat with psychotherapy. You can try pharmacotherapy, but because of the paranoia, you may not be able to get them to take the antidepressant or anti-anxiety or possibly even an antipsychotic. Seems like I'm forgetting something. Schizoid personality disorder. It is not schizophrenia. They are aloof, tend to prefer solitary activities, absence of humor, lack of interest in forming relationships, disengaged, uninterest in social interaction. May seem cognitively impaired and have difficulty working. Functional abilities and levels of adjustment vary among the patients. Schizoid. Generally unable to perceive or express strong emotions. Cognitive behavior therapy, group therapy with others who are also learning interpersonal skills. Pharmacotherapy may include antidepressants and antipsychotics. Schizotypical personality disorder, page 2010. It's different from schizophrenia. Schizophrenia is more severe. Some people with schizotypical can progress to schizophrenia, extreme social anxiety, eccentric behavior, depersonalization. They don't feel like they're part of the body and they feel disconnected, derealization. Understand those two terms. They have a detachment and restricted affect, negative affect because they're suspicious. Cognitive behavior therapy and pharmacotherapy, again, if you can get them to take the antidepressants, anti-anxieties. Culture considerations. There's a focus on diversity and culture on page 2012. Cultural considerations, a little paragraph on 2010. People new to the United States may seem paranoid when behavior could result from unfamiliarity with American customs. Some cultures condition girls and women to avoid social situations, and some cultures encourage expressive, exuberant behaviors, while others unemotional behaviors. And some other I didn't do lifespan in the slides, but on 2013 in lifespan, personality disorders in children, many times traits appear in childhood and do not persist into adulthood. But a personality disorder may be diagnosed in children and pre-adolescents in relatively unusual cases where the child's behavior's maladaptive traits appear pervasive and persistent. For a personality disorder diagnosed in childhood, the features must have been persistent for at least 1 year. The exception is antisocial personality disorder, which cannot be diagnosed until age 18. Younger patients with similar behaviors diagnosed with more age-appropriate disruptive impulse control or conduct disorders. Research has been focused on genetics. Okay, I think that was it. And I think there was one other thing. Page 2006. This is Antisocial personality disorder. To confirm diagnosis of antisocial personality, an individual must illustrate dysfunction as illustrated by egocentric behavior, including pleasure-seeking and unlawful behaviors. Impairments must exist in interpersonal functioning, lack of empathy, and remorse for wrongdoing. Okay, I think that was it. I'm going to make sure I covered all. Nursing diagnosis, page 2015. Just remember, diagnosis links up with your assessment, planning, diagnosis, intervention, your whole ADPI. Okay, and that is the end of this recording.